So, hello, good morning, good afternoon, and good evening to all of our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from the USA, Prof. Christian Gagnaniello. Prof. Gagnaniello is an assistant professor in the Department of Neurosurgery at the San Antonio University of Texas, USA. He is also the chief of Department of Neurosurgery at the R.D. L. Murphy Memorial Veterans Hospital, San Antonio, Texas. He was the past director of the Ammerman Micro Neurosurgery Laboratory at the Washington, D.C. He has received several awards in his country for his contributions to neurosurgery, namely the Neurosurgery Teaching Award from the UT Health San Antonio and the Best Doctor Award for Neurosurgery Doctor in San Antonio. His clinical interests are focused on skull-based surgery, especially minimally invasive surgery. He has published extensively in several internationally peer-reviewed journals, and we're extremely honored to have him today at our webinars, and today he'll be talking about endoscopic odontoidectomy. The speaker for the second session of today is our honorable guest from Japan, Ms. Chisato Fuseya. Ms. Fuseya is a nurse practitioner at the Fujita Health University, Japan. Ms. Fuseya is an important member of the neurosurgery team led by the honorable president of ACNS, Prof. Yoko Kato, and she is an integral part of the neurosurgical education among the nursing division of the ACNS. We are extremely honored to have her today at our webinars, and today she will be talking about the current role and future outlook of nurse practitioners in Japan. The chair for the first session of today's webinar is our honorable guest from Japan, Prof. Tatsushi Inou. Prof. Inou is a professor in the Department of Neurosurgery at the Fujita Health University, Aichi, Japan. He was previously an associate professor in the Department of Neurosurgery and Department of Spine and Spinal Cord Surgery at the FHU, Japan. His clinical interests are focused upon skull-based, spinal cord, and spine surgeries. We are extremely grateful to him for accepting an invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is an honored guest from the USA, Ms. Kathy Cartwright. Ms. Cartwright is from Kansas, Missouri, USA, and she is a pediatric clinical nurse specialist with 20 years experience in pediatric neurosurgery. She has also worked as a staff nurse in PICU, as an educator and a director of the Advanced Pediatric Professional Development. She is a past president of the American Association of Neuroscience Nurses and co-editor of 3 editions of book Nursing Care for Pediatric Neurosurgery Patient, co-editor of chapters in the AANN core curriculum, and president of the WFNS Nurses Division. We are extremely grateful to her for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Tatsushi Inou.
Good afternoon, ladies and gentlemen. Today's session focuses on endoscopic odontoidectomy, a fascinating and highly relevant topic. The odontoid process is a small structure, but it plays a crucial role as a landmark for the anterior craniovertebral junction. Conditions such as trauma, vaginal invagination, and tumors often necessitate surgical interventions. Traditionally, this has been approached transorally using a surgical loop or microscope. However, due to the restricted working space, these techniques can sometimes be challenging. In recent years, endoscopic techniques have emerged as a valuable alternative for addressing these challenges. Tonight, we have the privilege of hearing from an esteemed expert in this field, Dr. Gragnaniello. Dr. Gragnaniello, welcome. The floor is yours. Go ahead.
Thank you so much for the very kind introduction. We will try and make a little bit of some sense of, as you said, this very important structure that sometimes becomes surgically relevant and needs to be approached and removed. And so we'll see what are now the latest and in surgical removal of this process, and also looking at some of the surgical anatomy and especially the indications, and also how to make this safer for the patients and make it a little bit more better tolerated. So without further ado, I will share my screen again and get into the nuances of these. So So I have no disclosures that are relevant to this talk, and we'll start with a slide that's a little busy, and I apologize for that. But the indications for this keep on changing somehow as our surgical techniques, especially from posterior, become much better, and as also our medications for some diseases become better. So we are doing far less odontoidectomies than we used to. But still, to this day, it's true that if there is an irreducible ventral, that bony or ligamentous compression of the brainstem, so irreducible means for the students that cannot be otherwise addressed with manipulation of the spine. These will benefit from an odontoidectomy, as well as some cases of platybasia with the retroflex odontoid process, and we show you some images of that, as well as basilar invagination or rheumatoid pannus that has not responded to medications or not enough. And some cases of chordomas and chondrosarcomas that go all the way down, the cervical spine into the C2, sometimes C3. Some symptomatic and compressive rheumatoid pannus that we said that even that stay so even after posterior stabilization, they don't resolve. So as a second stage after some time. Cases of also the odontoideum and some other odontoid process retroflexion associated with Chiari that result in compressive myelopathy. Yeah, more in general, I mean, one can say that these are all craniovertebral junction abnormalities of any origin. So we spoke about congenital, inflammatory, developmental, traumatic, when there is a pure ventral, irreducible cervicomedullary compression. What's the advantage? So the advantage is that we immediately restore spontaneous breathing if we go through the nose and not through the mouth. We'll see why. We will be able to resume in our patient immediate oral feeding, which is not the case if we go transoral, which is another way, as we know, and we'll show. We have a direct approach to the odontoid, even if there is a platybasia. So if there is an eye position of the dents, we'll see on lateral X-rays. We don't need to split the soft or hard palate, which is another incredible advantage of this technique. We don't need to retract the tongue. We don't need to cut any of the tongue. We will never need to split the mandible. And we no need to plan for a tracheostomy or for prolonged orotracheal intubation after the procedure. So essentially, we decrease, minimize, or nullify all risks to swallowing, especially to swallowing and also to breathing. And so anything above the palatine line is especially suitable for this technique. So why should one not do it then if it's so good? Well, it's technically demanding. It's a deep and narrow corridor, and anything below the nasopalatine line, then it becomes more challenging and requires adjuncts that kind of limit the advantages, make those less relevant. So that is the nasopalatine line. So you can see how most times you can get all the way to the base of C2 and sometimes even C3. And there are other things that we can do to increase that surgical window. So what's the historical gold standard here? So the most, historically, we've done this transorally. or transcervically with the aid of a microscope. Sometimes we've done extended approaches that have included maxillotomies or the division of the palate or the maxilla or the mandible, like we mentioned. For these approaches, there is a need for oral retraction, and as we mentioned, the endonasal route avoids all of these because it does not interfere with the palate or the tongue. And this is one very important thing, the velopharyngeal insufficiency, because every time you start acting on the soft palate, you may have a very prolonged dysphagia, but also dysphonia, which is another relevant issue here. This is a case from a paper where you see a very high dens that goes all the way into the skull, and you can see how this would be very difficult to approach with the standard of care. If you imagine going through the mouth here, you would have to be pulling these dents down. That'd be very difficult. So Dr. Crocker, who popularized the transoral technique back in the UK, and observed that another issue with this technique, with the transoral technique, would be oral sepsis, or they will be very difficult if there is a reduced opening of the mouth, or if there is a fixed flexion deformity of the head on the neck, so that for which you cannot open the mouth. So all issues for which you cannot open the mouth, they make this very difficult and represent at least a relative contraindication. A big tongue, as one can imagine, also gets in the way. If anybody has seen the retractor for this procedure, it pushes the tongue down, and if you have a very big tongue, that may be a big issue, leading to a lot of swelling post-operatively and issues with ventilation. So when did this all start? And giving thanks to those that came before us and made this possible. Dr. Kassam and his group, Dr. Gardner and Dr. Snyderman, Dr. Karau, and Dr. Spiro published this paper many years ago, about 2 decades ago, where they essentially performed an endoscopic transnasal approach, and they resected the odontoid. They were able to open the arch of C1, they managed the rhinopharyngeal mucosa, and they showed us and led the way. But going back to indications, we mentioned this word for the medical students, platybasia. What is it? It's an abnormal flattening of the skull base, which is the skull base of an angle of over 143 degrees of a line that joins the nasion with the pituitary, the center of the pituitary fossa. That's our horizontal line, with a line that joins the anterior border of the foramen magnum, and that's our vertical line. So it's normal between 125 and 143. Anything above is platybasia, and anything below that, it's called the basilar kyphosis. So is it always a problem? No, it's not symptomatic unless there is a basilar invagination. And so that's another point. We don't just treat images here. What's a basilar invagination? Again, defining our territory here. So it's a congenital or acquired CV junction abnormality where the tip of the dents projects above the foramen magnum. Many times it's accompanied by assimilation of the atlas, and you can see a type 1 and a type 2 here on the panel on the inferior left side. So again, anytime the tip of the odontoid projects above the foramen magnum. We mentioned another reason for this approach is the ossodontoideum. What is that? That's the separation of a portion of the odontoid process, which is marked by corticated bone, and can be different sizes. It can be situated in the normal position of the odontoid, but can have a wide gap. And in this case, we would call that orthotropic, or it can be displaced in the area of the foramen magnum, and we call that dystopic. This may have no bony links to the body of the axis. You can see the images up here of a corticated ossodontoideum, and after its removal. So in brief, I mean, this is a technique that's especially well suited for pathologies, again, above the palatine line that makes it ideal. So where would you start? So for every surgical approach that we do, we want to begin with thinking about positioning and opening as well as closing. So the patient is positioned supine with the head in a neutral position, fixed in a Mayfield. I prefer to use a Mayfield anytime there is a lot of skull-based manipulation, as I'm afraid that all movements of the skull base, especially with drilling or pulling bone down, they may make this much more dangerous than it needs to be. The body is positioned horizontal. I place everybody that undergoes a skull-based procedure in a beach chair position so that they may not slide on the bed. So we obviously put pressure points. We pad every pressure point. The nasal tip is the highest point in our surgical field, as you can see, and there's a little bit of traction on the head just to try and decompress some of the cervicomedullary junction. That also depends on a case-by-case base. What can we do to improve the view? I was telling you that the soft palate and the palatine line are so important. So historically, nasogastric tubes were passed through the nose and through the mouth and pulled down. We moved away from this, and with my ENT partner here, we essentially put a stitch in the uvula and tied down, and we found that to be much more effective, and you don't have all these tubes in the way of your approach. What are the steps to exposure? So how do we get there? So like I said, we try to think about closing before we open, and that's always the case no matter what we do. So most times we would harvest a pedicle nasoseptal flap that would help tremendously with the healing, but also with to decrease the chances of any CSF leak postoperatively. So this is usually elevated from the right side, and it's tucked into the middle meatus, and it stays there until until it's time for closure. So the middle and the inferior turbinates are displaced laterally. I think it's very useful in this procedure with very little price to pay to take some of the inferior turbinates. It makes for a much nicer view and for a much wider field with very little cost to the patient. Then the next step will be a posterior septectomy, where essentially removing some of the posterior septum allows for forehands technique, but also for it really improves the binostril access within with the maneuverability of our instruments, and makes it for a less sword fighting between the ENT holding the scope and another instrument, and the two instruments held by the neurosurgeon. And so this on the right is the image of the essential of the surgical field in the beginning, with where we see the sphenoid sinus at the top, the rhinopharynx, which is the goal of our exposure, and then lateral to that, the thorax tubarius and the eustachian tubes, which are incredibly important landmarks for the carotid arteries, that they posterior lateral to that, and now considerations about what to do and how to open the rhinopharynx are dictated by the pathology at hand. So most times one can think about doing a U-shaped flap, or just an open on the midline. Whenever I can, I think the midline incision it's safer and it's nicer, because it goes through mostly avascular planes, and it shows us the muscles at the back that can be removed to make room and get us to our bony structures in a much cleaner way. So what needs to be avoided at this level? The eustachian tubes that are on the right, on the sides, so laterally, that precede the carotid arteries and the vertebral arteries, and the sympathetic chains that run around there. So once we've done this exposure, we start incising the mucosa, we will find the pharyngeal muscles at the back of the mucosa, and essentially we're gonna extend this all the way to the inferior aspect of the clivus superiorly, and down to the body of C2 inferiorly. We can use, obviously you've seen, probably you noticed on the initial picture of the approach or the positioning, that we use navigation for these cases. So whenever available, I think navigation is a great adjunct. So we can bring this incision all the way down to C2, and you want to get through the midline raphe, as I said, just stay midline, nice and safe, and between the pharyngeal muscles all the way down to the ALL, the anterior longitudinal ligament, that we're going to show where this attaches all the way down to the bone of C1. At this point, the ENT instrument, the microdebrider, is very useful to debulk some of these muscles, as this will make a much better and bigger exposure for the surgeon going down this narrow corridor. So at this point, we removed some of this muscle, which can be seen on the top right image here. Well, you can see RPM is the retropharyngeal muscle. So we make a window here, and we get all the way down to the bone. What we're gonna see at this point is the C1 arch and the clivus. But one thing to be said is that in cases of platysmaphasia, we need to start much higher. You can see that at that point, a sphenoidotomy is needed, and so anything that that's necessary to get you to this exposure in the layers that are above this and preceding this need to be done. So again, for platysmaphasia, sphenoidotomy needs to be done. Sometimes the removal of some of the clivus is necessary in cases of basilar vagination to get to this exposure. So everything that needs to be done to get to the arch of C1 and the odontoid process needs to be done before getting there. So how do we go about getting to the odontoid and how to take it out safely? So the first step would be to drill the arch of C1. At this point, you want to be safe doing this. So a high speed drill is a great tool for this, and I would recommend cutting just as you would do from the back to essentially drill this from lateral to medial, and then use angle curettes and caissons to complete your resection. You don't want to violate the medial aspects of the lateral masses of C1. That's really your lateral limit here. And so, because we will see, and this is debated, then there are lots of studies saying that, if you preserve the arch, you help stability. I'm not quite sure that to be the case, so we will discuss this in the end. And so at this point, and I'm going to show you all the ligaments that are involved in here. The odontoid process needs to be freed by the apical and alar ligaments using a combination of sharp and angle curettes, straight and angle curettes. And again, in order to be safe, the bone is cored out in the middle, hollowed out with a high-speed drill, and then as you get to the cortex, we switch to a diamond drill so that we prevent going through it in an uncontrolled fashion. And then, as you can see me doing on the left side, we fracture this on itself, so that's the safest way to take this out. But what are the ligaments? Because some of the strongest ligaments of the human body are around here. So the ALL must be opened, and we can see the ALL here on the section on this diagram. The ALL covers the atlanto-occipital membrane, which is a broad and dense fibrous tissue, as you all know, that goes from the inferior border of the foramen magnum to the edge of C1. Once we get to the dens, it's surrounded really by ligaments. The alar, which by the word, as the word says, it looks like a wing, and the apical and the cruciform ligament. The alar are thick and connect to the dens to the occipital condyles, and the apical ligament goes to the bottom of the foramen magnum. The transverse ligament, the tectorial membrane, all of the other ligaments are then removed to decompress the dura, and any soft panels is gently dissected away, again with a combination of different curettes and caissons. If there is any adhesion that's really severe to the dura, obviously one should try to leave it alone. So debulk it as much as possible to a thin layer, and leave it attached to the dura to avoid the CSF leak, which would be, again, something more to deal with at this point. When is it that you're done? When is it that the operation is done? For whatever reason this operation was done, which is usually compression, you want to see the dura re-expand. And once you see the dura re-expand, at that point you're done. And you can see the dura here on this cadaver dissection. So new techniques are coming out and have been coming out for a while, where there is a decompression and reduction at the same time. I think this is quite elegant, where the odontoidectomy is combined with a posterior reduction. I think this is pretty cool. I was saying that we thought that just taking just a little bit of the arch will leave the stability of the CV junction here. This has been found not to be necessarily true, and so there are studies now, biomechanical evaluation, that say that you probably still need a posterior fixation, and I certainly do believe in that, and I do that. And this is a case that I think is good to show that we've done recently, where a young woman that had been fused prior somewhere else came with a hemiparesis. This is her CT scan, and this is her MRI that shows something hyperintense on T2, pushing on the spinal cord on the right side, and hypointense on T1. Essentially, we provided her with the odontoidectomy and the posterior fixation, and this proved to be a facet joint cyst. So we removed the dents and essentially got into this very foamy, gunky material that was the content of the cyst. And patient did much better and went back to baseline afterward. This is a video of the depths that you reach when you get through this approach. You can see that those are the pharyngeal muscles we went between and removed, and that's the remnant of the arch, and that's the dura at the back there. In conclusions, and I think I'm probably within my time and leaving you some time for questions. We think that this is a minimal invasive technique, or minimally invasive enough, that's well tolerated, and I think it's important to continue to provide fixation at the back, and you can consider a second stage reduction in some cases where after the first stage, it doesn't look like a complete reduction has been achieved, especially in these cases of these very high riding denses. So I think that's what I got. So I'll leave the time for some questions. Thank you.
Thank you very much. Prof. now.
Yes, thank you. Thank you for your excellent presentation, Dr. Gragnero. He has provided a comprehensive overview of endoscope procedures around the odontoid process, including technical innovations and indications for various pathologies. We greatly appreciate the insightful information shared. This session is open for question. Any question? Anybody?
Well, there is a question in the chat box asked by Dr. Harsh Parekh, and he's asking, how often have you encountered dural tears, and if yes, then how do you manage?
So I fortunately not had any unintentional tear, but we certainly treated also some intradural pathology, which essentially is pretty much the same thing. And so you would treat this just as any other CSF leak. We would raise a flap just at the beginning of the operation, and so we would have a multi-layer reconstruction depending how big the defect. Certainly, with either Duragen or Alloderm or fascia lata, depending on how big. We don't do any rigid buttresses at this level because of the vicinity of brainstem and the possibility that this may move. And then so we'll do an inlay and then an overlay with the fascia, followed by some Surgicel and possibly some glue and some nasopores to keep the repair in place for a few days.
Right. Thank you very much. Any questions from Dr. Liu?
Thanks, Raja. Thanks, Prof, for a very nice lecture. I have three questions, Prof. First one, in your case, I saw there's some navigation device there. Do you use navigation, and how accurate navigation if you do not have intraoperative imaging? My second question, Professor, you mentioned that the limitation is due to the hard palate. Would angle scope, like 45-degree scope or angle instrument, will be helpful in your surgery? My last question, Professor, I saw the patient that you prepared over the anterior iliac bone. Do you harvest the anterior part for the posterior fusion always, or any occasion that you take from posterior iliac? Thank you, Professor.
Okay, thank you for the interesting question. So yes, we use navigation as much as possible, and sometimes this needs to be recalibrated during the surgery. So these days we use many times we use the ENT navigation, which is much easier to recalibrate during the procedure. So that's really a very nice tool, so that we don't use the neurosurgical navigation anymore. That if something moves, then we don't really have any other navigation for the rest of the case. And then what was the other?
For the hard palate, the angle instrument.
Yeah, so we usually we absolutely use angle scopes, and it's very interesting because while when we do most of our work to the pituitary and the anterior cranial fossa, we use reverse post endoscopes. In this case, we use just the normal endoscopes because we're looking down. So we would use normally 0 and 30 degrees, and then by the end of the procedure, we will put in some 45s. We don't operate most of the cases done with 30 degrees, and by the end we will use some 45s. And this is a great point for the trainees, because when we use when we use 30 degree scopes, our instruments are above the scope. In this case, as we're operating down, our instruments are below the scope. So it kind of changes a little bit the way you think about endoscopy.
And iliac bone harvesting? Yes, because I saw that you have a bone graft for the posterior fusion.
Oh, yes.
You harvest from anterior or posterior?
That's posterior. That's posterior, yes. So yes, I tend to fuse these patients. I think they're still unstable, and I like to, I'm one of those that doesn't believe in OC fusion, and so I usually put a 3 cortical graft that's wired between my occiput and whatever bone I have at the bottom. So in this case, I have the arch of the atlas, and I think in my series they fuse really well that way. So. It's a nice way to do it.
Thank you, Professor.
Thank you, Professor. First of all, let me thank you for this wonderful presentation. I would like to ask you 2 questions. One is, you said you may use a traction at the beginning of the surgery before you apply the pins. So do you use the traction under neuromonitoring, or?
Yes. So these cases are monitored, all of them, and if we use traction, we certainly do it we do it slowly and under neuromonitoring. So 5 pounds at a time with neuromonitoring, absolutely.
Right. Thank you. And what is like the post-operative period? Like, when do you start the oral feeds, or do you insert the rail strip earlier? What
So
is the protocol
for these, unless for some reason I had to make incisions to the soft palate to get lower, like we've done it sometimes for chordomas that go down to C3. we don't have any issues feeding the patient post-op day one, and the tube comes out the same day. So patient gets extubated at the end of the procedure, unless it's been a very long day and for some other reason they're kept intubated overnight, but otherwise they get extubated and fed right away. I think that's
Is
the
it like
biggest
you begin
advantage.
with the oral fluids
Yes,
first
yes.
and then move on to solid?
Yeah.
Right, thank you. And do you use a lumbar drain in your surgery?
So we only use lumbar drain if we had a CSF leak that we think it's categorized as one that's a higher grade. Otherwise, no need. If this is all extradural, there's no need for a drain.
Thank you very much.
So we don't put one up front. We only put it at the end if we need to.
Right. Thank you very much. We had a wonderful session. And Prof, any comments and remarks from your side?
Yeah.
Thank you. Thank you so much. It was an incredible opportunity. Thank you.
Prof,
Yeah. I have one question. You mentioned about the anterior decompression. That is a direct decompression. On the other hand, posterior C1 C2 dislocation is indirect decompression. And in some cases, using indirect decompression, we can skip the anterior approach. How do you manage or select the approach by both anterior, posterior, or simply posterior using indirect C1 C2 destructions? How is your strategy to complex pathologies? Would you please?
So I think the mainstay these days is still a posterior decompression alone. There are very few cases that really require an odontoidectomy. So say for any cases of basilar imagination, but also all the cases of pannus, we would always prefer a posterior approach first to see how much decompression we get, and then only in selected cases we do an odontoidectomy. I mean, we may do very few in a year. So it's really this is a posterior operation first, and then maybe if the pathology persists, then you can consider an anterior approach of some sort. And I know somebody is going also lateral these days, so some other form of approach, some other route.
Thank you very much. We can hear the concluding remarks from your side, Prof.
Yeah. Thank you for your nice comment. And now we can close this session today now.
Well, thank you. Thank you very much, Prof. and Prof. Gragnaniello. This was a wonderful session, and we learned a lot from your lecture. I would like to inform our viewers that this has been broadcasted on YouTube, WeChat, and Zoom. And thanks to Prof. Shubin, as of now, we have around 690 people who have joined on different networks. So thank you everybody for joining. And we'll move on to the second session and hand over this podium to our very honorable chair, Ms. Kathy Cartwright, who would say a short introduction and invite Ms. Chisato Fusaya for her lecture. Over to you, Kathy.
Thank you. Well, the role of the nurse practitioner is extremely important for the neurosurgery team. The scientific knowledge and the skills that a nurse practitioner brings is invaluable, and they're key to improving the patient experience. The nurse practitioner role can vary from country to country, even from into states. It can vary from even in the institution where the nurse practitioner is practicing. So it's important that nurse practitioners practice to the full extent of their education and their scope. So today, Ms. Fusaya will describe the current state of and the future of the nurse practitioner role in Japan.
Okay, thank you for kind introduction. So I'm going to share my presentation. Thank you for giving me the opportunity to join the ACNS webinar. Again, I'm Chisato Fusaya and Japan's nurse practitioner. I have no COI to declare. Let me introduce myself a little bit. So I have two kids, 16 years old and 14 years old. Both of them are girls. And my hobby is traveling to other countries and cooking. So today I'm going to discuss the NP's current situation and future outlook on NP in Japan. Now I'm working at Fujita Health University Hospital, which is in Aichi, Japan. Aichi is the most populated city in Japan. Fujita Health University has 4 hospitals. In total, 37 NPs work at 3 of them. This is the title. So there are topics for today. First, I'm going to talk about what NP is in Japan. Second, NP system in other countries. And lastly, I'm talking about NP's future outlook in Japan. At first, let me introduce Japanese nurse practitioner system. Most of Japanese nurse practitioners belong to the Japanese Organization of Nurse Practitioner Faculties called JONPF. The purpose of JONPF is to contribute to people's health. It also provides nurse practitioners education, practices, and research. In 2008, the training system for NPs started as a master's course in graduate school. In 2009, Japanese Society of Nurse Practitioners, called JSNP, was established. The following year, in 2010, the Japanese government decided to create a nurse practitioner system similar to the US. In fact, doctors' overwork has always been a major issue in the Japanese medical field. Moreover, with the shrinking birth rate, the number of younger and middle-aged people in the workforce will decrease over time, leaving a smaller segment of the population to provide for the elderly population, which is rapidly growing in number. In 2015, JSNP changed its name to the Japanese Organization of Nurse Practitioner Faculties for incorporation, and the primary regulation for nurses has changed for the NP system. Next, I'm talking about acquired 7 competencies of nurse practitioner. According to JONPF, NPs require some competencies. First, comprehensive health assessment. Second, management of basic medical procedure. Third, skilled nursing practice. Fourth, skilled nursing management. Fifth, collaboration and working in medical team. Sixth, utilizing and developing medical, health, and welfare system. Seventh, ethical decision-making. So NP operate within hospitals and medical practices in much same capacity as a doctor. The tasks of NP require variety of technical skills as well as more universal skills. So nurse practitioners' education also requires some skills: assessment skills, leadership skills, good communication skills, and improving emotional intelligence. About leadership skills, leaders who plan early and enlist the help of nursing staff to assist in developing and evaluating organizational plans can ease the stress and uncertainty of change. Moreover, mastering communication improves successful outcome across other skills. In addition, emotional intelligence helps to helps the Japanese nurse practitioner to be able to build stronger relationship and to perform well in severe situations. So there are 19 universities which are authorized by the JONPF to provide nurse practitioner training throughout Japan, so Hokkaido to Kyushu. According to the JONPF, there are 872 NPs registered with the JONPF. Next, I'm gonna introduce how to become a nurse practitioner in Japan. Here are steps to become a nurse practitioner. First, you have to be a registered nurse. To become a registered nurse, you have to take a nursing program at university, community college, or professional training college. After finishing the program, you have to take the registered nurse board exam. Then, you also need to gain an experience of no less than 5 years. Second, you need to finish a master's course for 2 years. Third, you have to pass the exam for NP license. So NP license in Japan is not the national license. It's certified by the JONPF. Introduce about the master's course at Fujita Health University. The NP course takes 2 years. The graduate students learn advanced medical knowledge in the lectures. Also, they go through clinical training for over 720 hours at Fujita Health University Hospital. During the first year master's course, students take some classes. The main subjects are advanced pathophysiology, pharmacology, and physical assessment, called 3P. By the end of the first year, they have to pass objective structured clinical examination called OSCE before they can proceed to clinical practice. An OSCE examination consists of several different scenarios, such as airway management, replacing a tracheal canal, fistula management, inserting a peripherally placed central catheter for injection, a radial artery line, wound management, and bladder fistula management. They are assessed by examiners, physicians, or nurse practitioners at each station and receive a score based on performance. During their second year in master's course, they visit different departments, including neurological surgery, cardiovascular surgery, gastrointestinal surgery, thoracic surgery, endocrinology, anesthesiology, emergency room, intensive care unit, and primary care. They also write a master's paper based on clinical practice. And end of the year, they take NP license examination. Let's talk about NP's education. NP education in Japan has a different process for each hospital. So I'm going to talk about the NP education, a case at Fujita Health University Hospital. The education program for NP takes 2 years. NPs have 38 specific medical interventions and non-specific medical interventions. The 38 interventions specified and grouped into 21 categories cannot be performed by registered nurses. NPs don't only need skills for those interventions, but also discernment of whether they should do them or not. Let me introduce one of the NP trainees' schedule in the first year. They go through clinical training in some departments at Fujita Health University Hospital. During the first year of training program, NPs belong to some departments for 1 to 2 months. The main aim in the first year is for them to gain a wide range of knowledge through clinical practice. This is scheduled in the second year. During their second year of training program, they must have training in different departments for 3 to 4 months. Looking forward to the following year, they are going to develop their assessment skills, master medical techniques, and management skills. And on their third year, they have to decide which department they want to work for. So I'm introducing NP's tasks in Japan. There are a part of 38 specific medical interventions, such as removing a thoracic drainage tube, removing necrotic tissue, securing a radial artery line, replacing the position of tracheal tube, inserting a central venous catheter, this means a PICC, and removing an abdominal drainage tube. So one of the main specific medical interventions is inserting a PICC. You already knew it, so PICC is the peripherally inserted central venous catheter. I'll introduce you to a PICC placement at Fujita Health University Hospital in Toyoake. In 2023, the total number of PICC placement was 1,661, and P's inserted 1,494 PICC placement. Physicians inserted 133 PICCs, and registered nurses who took special training and inserted 33 PICCs. The result shows that NPs inserted PICC around 90% of total. There are some non-specific medical interventions. For example, NPs assist surgeons during operations. In laparoscopy, NPs maneuver the camera. They learn and train from surgeons. And NPs suture surgical wound in the end of operations. In addition to that, NPs are not only giving assistance, but they also give orders to patients based on the assessment under doctor's supervision. Let me give you a quick overview about neurological surgery department. During the operations, NPs assist surgeons. So this picture shows that spinal surgery. This picture is endovascular surgery. This picture is endoscopic hematoma evacuation for chronic subdural hematoma. This is removing subcutaneous drain. This is preparing for endovascular operations devices. These pictures show that NPs are able to do some procedures instead of the doctors. Furthermore, there are a lot of emergency stroke patients. At that time, NPs go to ER checking the patient's symptoms. For example, National Institute of Health Stroke Score called NIHSS, whether patient takes anticoagulant or antiplatelet, and indication criteria of TPA, checking the CT or MRI with resident. Then telling supervisor doctors a patient's condition. After that, if patient has ischemic stroke, NPs prepare for TPA and endovascular thrombectomy. After finishing the operation, NPs treat the patient in neurointensive care unit under doctor's supervision. So NPs conduct patient care throughout ER to discharge. Here are some NPs article. So according to Tomoka Katayama, it was demonstrated that by assigning two NPs to the neurosurgery department, the doctor's overtime work hours was decreased, and the rate of paid leave use was increased. And Dr. Shuichi Harada announced that collaboration between neurosurgeons and nurse practitioners is one of the most important issues in team medical practice. And also, Dr. Kazuya Honda maintained that NPs are able to do high-quality procedures under doctor's supervision, and also they coordinate patient treatment between patient and medical staff. Oh, I'm sorry. So let me give a short talk about Japan. We have a lot of traditional places and food. The shrine and the traditional sports, sumo, and Japanese castles. This is Himeji Castle, maybe. And Japanese cuisine, sushi, ramen, and Tokyo Tower, and cherry blossom. If you come to Japan, you should come to these places and try some Japanese food. Let's move back to the agenda. Secondly, I'd like to talk about NP system in other countries. Advanced practice nurse system is similar to Japanese nurse practitioner system. Many countries have the advanced practice nurse system. For example, USA, Canada, UK, Australia, Singapore, Japan, New Zealand, Sweden, Norway, China, and Korea, etc. They have their own roles and different tasks for each country. I'm talking about APN Advanced Practice Nurse System in the USA, which one of the historical countries in terms of APN around the world. So I have done my own research on the NP system in the USA, but Miss Cartwright, if there are any mistakes in my finding, please kindly let me know after the presentation. In the USA, from 1960 to 1970, rising medical costs led to a shortage of home doctors and physicians for the urban poor sparking movements to promote equality across race and gender, as well as consumer and women's rights movement. Like this suddenly changing situation, in 1965, NP program was first established at the University of Colorado. After that, in 1985, the American Academy of Nurse Practitioners, called AANP, was established. NPs built the success result. In 1997, NPs finally were able to gain direct insurance reimbursement. So next, I'm going to introduce how to become a nurse practitioner in the USA. Here are steps to become an NP in the USA. First, you have to be a registered nurse. Then, you also need to gain 1 or 2 years of experience. Second, you need to finish a master's course or a doctor's course. Then, you need to select the specialties and pass the NP's board examination. Third, you can work at a hospital or a nursing home or a clinic as an NP. And you need to renew your certification every 5 years. Here are NP's specialties in the USA. According to the American Association of Nurse Practitioners, there are over 385,000 licensed NPs in the United States. Here are the most common nurse practitioner specializations by primary certification area, according to a 2022 survey by the AANP. Family nurse practitioner accounts for 70% of nurse practitioners. A family nurse practitioner is an advanced practice nurse who manages the healthcare and individuals and their families by providing preventive and primary care, promoting health and well-being, and helping their patient manage chronic conditions. Family nurse practitioners conduct routine checkups and assessment, order and interpret tests, make diagnoses, prescribe medications, and initiate and manage treatment plans for their patient. In the USA, every state has a different policy about NP system. In the case of full practice, state practice and licensure laws permit all NPs to evaluate patient diagnosis, order and interpret diagnostic tests, and initiate and manage treatment, including prescribing medications and controlled substances under the exclusive licensure authority of the State Board of Nursing. This is a model recommended by the National Academy of Medicine, formerly called the Institute of Medicine, and the National Council of State Boards of Nursing. In the case of reduced practice, state practice and licensure laws reduce the ability of NPs to engage in at least one element of NP practice. State law requires a career-long regulated collaborative agreement with another health provider in order for the NP to provide patient care, or it limits the setting of one or more elements of NP practice. In the case of restricted practice, the red one, state practice and licensure laws restrict the ability of NPs to engage in at least one element of NP practice. State law requires career-long supervision, delegation, or team management by another health provider in order for the NP to provide patient care. So next, I'm going to introduce NP's article in the USA. Of course, you may realize that there are similar article or findings in the USA as well. Let me give some articles. So Dr. Andrea mentioned that this economic evaluation found that a heart failure nurse practitioner service was cost-effective and could potentially save 109,474 per quality adjusted life year at 12 months and save 270,667 per quality adjusted life years at 3 years. The heart failure NPS service was the dominant model compared with usual care. And Dr. Chan Fan Liu, a PhD, presented that patients reassigned to NPS experienced similar outcomes and incurred less utilization at comparable cost relative to MD patients. NPs may offer a cost-effective approach to addressing anticipated shortage of primary care physicians. And PhD Jordan presented the associations estimated here also suggest that increased use of NP-led primary care could be cost neutral or cost saving. And so NPs are coordinating with the medical team. So next, I'm going to talk about the differences between Japanese nurse practitioners and US nurse practitioners. In the case of the American NP, they assess patients, order and interpret diagnostic tests, make diagnoses, and initiate and manage treatment plans, including prescribing medications. On the other hand, in the case of Japanese nurse practitioners, they can do the specific medical interventions that the Ministry of Health, Labor, and Welfare permits. And also they can perform non-specific interventions, but under doctor's supervision. I'm going to talk about the ACNS system in Singapore, which moved quickly to implement the administration work to make APN a national qualification. The main impetus behind the development of APN system includes the advancement of medical science and technology, specialization, shortage of physicians, and increased complexity of healthcare. According to Changen Nursing Department Institute of Mental Health Singapore, the National University of Singapore commenced the first Master in Nursing in Advanced Practice Nurse in 2003. In 2005, the Singapore Nurse and Midwife Act was amended to include APN certification and registration. The Act states that the title of Advanced Practice Nurse is protected by law and only allowed to be used by individuals certified by Singapore Nursing Board. Furthermore, APN certification was first commenced in 2007 and has evolved from the initial exit interview to national OSCE, and then to the APN internship is a portfolio and certification by the Committee for APN Competency. Certified APNs or APN interns who progress well during an integrated APN internship can further their education to gain prescribing privilege via the National Collaborative Prescribing Program, which was established in 2018 and co-owned by the Ministry of Health and the National University of Singapore. Then, the first certified APN collaborated with prescribers. So next, I'm going to introduce how to become an APN in Singapore. Here are the steps to become an NP in Singapore. First, you have to be a registered nurse and have a bachelor's degree with a cumulative average point of 3.2 and above, minimum of 5 years of continuous clinical practice as a registered nurse. Furthermore, an advanced diploma, postgraduate diploma, is required for acute care and mental health tracks. Second, to being the APN internship, you need to have a Master of Nursing program. And completing an 18-month full-time program must pass all academic models with a cumulative average point of 3 and above, and must pass the summative object. Third, you have to have an APN internship. It obtains a provisional license from the Singapore Nursing Board, completes a 12-month internship, and achieves the clinical portfolio. Requirement determined by the Ministry of Health APN Internship Committee and certification by the Committee for APN Competency. Fourth, you have to renew your practicing certification yearly. It obtains practicing certification from SNB upon successful completion of the internship, achieves the minimum hours of clinical practice and the minimum hours of continuing professional education as required by SNB. According to Singapore Nursing Board, an advanced practice nurse is a registered nurse who has acquired the expert knowledge base, complex decision-making skills, and decision-making and clinical competencies for extended practice. They are trained in the diagnosis and management of common medical conditions, including chronic illnesses. According to Singapore's Department of Statistics, there are 330 APNs in Singapore. APNs are currently certified in these 4 specialties: acute, medical surgical, community, and mental health. Acute care APNs practice in the intensive care unit and emergency departments. Medical surgical APNs can function in general and specialized clinical settings such as oncology, gerontology, cardiology, and neurology. And community APNs care for patients with common acute conditions and chronic conditions as the polyclinics and the community. Mental health APNs can function in both inpatient and outpatient psychiatric settings. So next, I'm going to introduce NP's articles in Singapore. So you may be aware that we can find similar articles in Singapore. Here are some NP's articles. So many papers have been published on NP's usefulness, like USA, Japan. So NPs are coordinating with the medical team like this slide. Lastly, I will talk about future outlook on NP in Japan. In Japan, nurse practitioners are not well known yet, so I hope to build recognition of them, and there will be an increase in their number. Also, they need standardization of their education because of keeping their knowledge and skills. The point of the NP system need legalization. They have to build the evidence which NP's competency, like other countries, for the legalization. As a result, NPs will play a significant role in patient care. It will need to opening more opportunities for them and letting them practice their profession on a more comprehensive scale. Thank you for your attention.
Yep, thank you for such an excellent presentation. That was really wonderful to hear about nurse practitioners in Japan. As you can tell from from your presentation, that nurse practitioners have a great deal of education. There is a strenuous pathway to becoming a nurse practitioner with education, communication. I love the 7 competencies that you laid out. Not only do they need to have the, the skills to do procedures, but they need to know how to collaborate and communicate with their colleagues and patients and families. I like the map that you showed of the United States, and what you described as nurse practitioner practice in the United States is accurate. As you can see from the map, states were very different. I live in a red state that has restricted nurse practitioner practice, and we are working to try to get a more unrestricted practice. But it was very interesting. And I also like the way you talked about how cost effective the nurse practitioner role is. Nurse practitioners can work to the top of their education and their skills, so that frees up neurosurgeons to go and do their thing in the operating room, and they can collaborate and I think improve patient outcomes by working together. So thank you very much for that.
Thank you very much.
Thank you for. Okay.
Yes, Ms. Fusia, please go ahead.
Thank you. Thank you for the wonderful comment, and thank you for giving me the very useful opinions. And so, if it's possible, could you tell me your U.S. nurse practitioners' tasks? For example, what you can do, how can I say, do works more detail. You are a pediatric nurse practitioner, is it
I'm
right?
a pediatric clinical nurse specialist, which is very similar to a nurse practitioner. It's an advanced practice nurse. It's interesting that you would ask, because our organization, the American Association of Neuroscience Nurses, just did a survey of neuroscience nurses on what they do, what is their scope of practice. And we are going to publish it in the Journal of Neuroscience Nursing, but we found that depending on what state you're in and how restrictive your practice is, and you have to have the education to be able to do these things, but some do lumbar punctures, some place lumbar drains, some prescribe medications, some of them do different procedures, putting bolts in the head. They may assist in surgery. So there's different things that they can do. There's outpatient procedures that they can do as well. They see patients on their own, like for follow-up. You do shunt checks, shunt taps, things like that. So, but they need the training, like you said, the training and the skills, and they have to, they're competent. But say, like a pediatric nurse practitioner could do a shunt tap and see patients in the emergency department when they come in for shunt failure. And the neurosurgeon can be in the operating room operating and consulted if there is something that needs to be done from that standpoint.
Okay. Thank you for the information about pediatric nurse practitioner. So in neurological surgery department, NPs can do a lot of things like in the US, but doctor's supervision, under doctor's supervision. But so yes, we hope our license will be legalization.
Okay.
Yes.
Thank you very much.
We have what's called a collaborative practice agreement. So the nurse practitioner and the neurosurgeon have an agreement on what the nurse practitioner can do.
Right. Thank you.
That's a good point.
We can take questions from the house. Prof. Christian, would you like to say something? How is it in your place?
Yeah, I think it's a fantastic overview that you gave us about the education and how the world is growing, and the practice of nurse practitioners has been more and more recognized, and how intense is the training, and rightfully so. I agree with Ms. Cartwright. I think in the US it depends where you are, and so the states that you are, the practice of nurse practitioners changes a lot. And also, I think the setting is important. If you're in an academic institution, maybe very different that of a private practice, for example, where the surgeon may be just the only one that's around, and if he's in surgery, so the practice may change a lot. Then if you have lots of residents available, so and again, there is an agreement between the parties of what's the scope of practice in your specific institution. And so, but I think the practice of nurse practitioners is becoming increasingly more complex, where they're doing more and more than they used to, and I think rightfully so. And they get more training. We see it also at the state level, at the our Texas Neurosurgical Society, where there are specific trainings with the hands-on for nurse practitioners, where more and more things are taught, including as Ms. Cartwright said, like bolts and EVDs and other things. And then it depends from the practice setting. I think that's probably most important part of it, where you practice. Great talk. Thank you.
Thank you. Thank you very much for your comments. If Professor Ino would like to say something, how the NPs have helped you in your practice in Japan?
Thank you, Ms. Fusea. Nice presentation. I'm very impressed with your talk. Actually, all my in all my surgery, the first assistant is Fujita nurse practitioners. I'm always helped by you and your colleagues, and I'm very happy to cooperate with you. Please go ahead.
Thank you. Thank you very much.
Thank you for the wonderful comment, Dr. Inoue Sensei. So thank you so much.
Thank you. Thank you so much. So we'll wind up this session with the final remarks from Kathy.
I think it was a wonderful presentation. I think that nurse practitioners have a key role to play in neurosurgery and in medicine in general. Increasing access is important, and I think nurse practitioners help increase access for patients. So I look to see this expanding in the future.
Thank you. Thank you very much. So I'll end this webinar officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Prof. Christian Gagnaniello and Ms. Chisato Fusea, as well as the chairs, Prof. Tatsushi Inoue and Ms. Kathy Cartwright, for the time and support for the ACNS webinars. A special thanks to my co-host, Dr. Liu Bun Singh, for joining me today. And also a special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 690 people who have logged in through all the different networks. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.